Hello. Hello. Good afternoon, everyone. Thank you for joining us today for our online event, Beyond the Basics, Medicaid and Financial Stability in Ohio. My name is Haley Aka. I'm Vice President of Operations and Strategy at the Health Policy Institute of Ohio. Our mission at HPIO is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending in our state. We are so grateful to our core funders who support HPIO's mission with their steadfast investment in our work. And I'd also like to thank our educational event series sponsors for their generous support of our events. If you are interested in being an educational event series sponsor for us at HPIO, feel free to drop us a note in the chat. There's still room to join. Well, we are really looking forward to our event today for the speakers who are joining us. I'm going to start our session today with some foundational information on Ohio Medicaid, and then we're going to hear from Dr. Crystal Hamilton from the University of Connecticut on her research on the impacts of Medicaid on financial security for low-income young adults. Then we'll have a presentation from Jesse Reed from CareSource on their life services program and the lessons learned on strategies and barriers to connecting people enrolled in Medicaid to work and other supports. We're also going to have some time set aside for questions from all of you. So please, as questions occur to you while I'm speaking, while our presenters are speaking, please feel free to drop those in either the chat or in the Q&A box here on Zoom. We'll be monitoring those throughout and we'll address as many as we're able. Slides and other information from today's event will be available after the session today up on the HPIO website. You can find those by going to hpio.net or healthpolicyohio.org and clicking on the events tab. Okay, well, with that quick and easy introductory information, I'm going to take us right into our content for today. Every 2 years, timed right in line with the beginning of our state budget process, we at HPIO release this document called Ohio Medicaid Basics. Medicaid Basics offers some foundational information in plain language about how the Medicaid program works, who's covered by Medicaid, how much the state of Ohio and the federal government spends on the program, and sort of any major changes to Medicaid over the past 2 years. The most recent version of this publication came out just last month, and it feels more relevant than ever that Ohio policymakers and those of us who aim to influence policy understand the basics of the Medicaid program. Medicaid is a public program that offers health insurance and other services to groups experiencing economic disadvantage. That includes children, families, and adults with low incomes, older adults, and people with disabilities. There are more than 3 million Ohioans enrolled in Medicaid, more than 1 in 4 people in our state. These Ohioans face unique challenges like expensive and complex health needs, challenges sometimes meeting basic needs, and in general, socioeconomic barriers to health and well-being. A primary purpose of the Medicaid program is to fortify individuals and families against the financial strain of receiving needed health care. Only certain groups of Ohioans with lower incomes are eligible to enroll in Medicaid. You can see those eligibility categories here in the middle. There's children, parents, and pregnant women, adults, and older adults and people with disabilities, again, all with low incomes. You'll notice that the adult eligibility category is often referred to as Group 8, which is a reference to the federal code that created this eligibility category. This group is also known as the Medicaid Expansion Group, added to Ohio Medicaid in 2014. And this has recently been a topic of a lot of policy conversation here in Ohio and nationally. Each of these groups has their own eligibility criteria, including different income thresholds. This is what these income thresholds look like for a variety of Medicaid eligibility categories and also for different family sizes. For example, adults ages 19 to 64 who are eligible for Medicaid under Group 8, they'll need to have a income of 138% of the federal poverty level. That's just over $36,000 a year, or about $17.5 an hour at a 40-hour-a-week job for a family of 3. The people working as carpenters and electricians, library technicians, vet techs, medical assistants, who are the sole earner in a family of 3, would all fall in this income range and likely be eligible for Medicaid under Group 8. Here you can see how enrollment in Ohio Medicaid has changed over the last decade. In 2014, there was a significant increase in enrollment when the Group 8 eligibility category was created. There are now 770,000 people enrolled to that group, over 770,000 people. There was another significant increase in 2020 during the COVID-19 pandemic, and enrollment has now been trending down. Now that the public health emergency is over and each person's eligibility for the program has been redetermined, still enrollment in Medicaid is about 9% higher now than it was before the pandemic. Here's how spending on the Medicaid program has changed during that same time frame. In the last state fiscal year, spending on Medicaid across all funds was nearly $39 billion. And you can see that most of those costs are paid by the federal government. So you see the federal government spending in light blue at the top. Dark blue at the bottom is Ohio's general revenue fund spending, mostly coming from the state budget. And then in the middle, that medium blue, is other designated state funds that go towards Medicaid. Federal funding has gone up significantly in the last 10 years, and state spending has also increased at the rate of approximately 3% per year. The federal government reimburses states for Medicaid expenditures using a matching rate called the Federal Medical Assistance Percentage. This is often referred to as FMAP. The FMAP rate is updated every year. It's based on a state's per capita income. And Ohio's current FMAP rate is 64.6% for most Medicaid expenditures, meaning that for a service provided through Medicaid, the federal government is going to pay 64.6% of that service, while the state pays the rest. But here we see, with this variety of bar charts, that the federal government matches expenditures for certain populations or certain types of services at different rates. So for example, here on the far right, we see that services for low-income adults enrolled in the Group 8 eligibility category are reimbursed by the federal government at a rate of 90%, meaning the federal government pays 90% of the cost. Speaking of Group 8, highest rates of enrollment in this group are found in metropolitan and Appalachian counties in our state. This is important to note as we communicate with our state policymakers about who is most likely to be impacted if Group 8 coverage ends. At the federal level, Congress is deliberating plans to reduce federal spending, including proposals to drastically cut funding for Medicaid. And in the midst of this, Ohio Governor Mike DeWine included in his state budget proposal a provision that if the federal share of Medicaid funding for Group 8 comes below that 90% FMAP, the state shall immediately discontinue all medical assistance for members of the Medicaid expansion group. That would significantly reduce access to healthcare for hundreds of thousands of Ohioans with low incomes, many of whom are employed. In 2018, Medicaid reported that 94% of Group 8 enrollees were either employed, in school, taking care of family members, participating in an alcohol or drug treatment program, or dealing with intensive physical health or mental health challenges. According to the Peterson KFF Health System Tracker, workers with lower incomes are much less likely to work for an employer that offers health insurance and are less likely to be eligible for that insurance. This is important because of the over 770,000 Ohioans who would lose coverage if Medicaid expansion ends, most would likely become uninsured. In Ohio, the proportion of adults with incomes below 200% of the poverty level who had employer-sponsored health insurance dropped just 2% from 2013 to 2023, meaning that these adults were less likely to have employer-sponsored health insurance both before and after the decision to expand Medicaid coverage. Here, the most notable changes that we've seen since 2013, when Medicaid expansion happened in 2014, has been a 53% drop in the uninsured rate and a simultaneous 53% increase in the percent of people covered by Medicaid. Medicaid expansion has not only resulted in decreases in the uninsured rate, it's also resulted in improved access to care. Here we see the percent of adults who went without health care because of cost and how that percent dropped from 2013 to 2021, as did the uninsured rate. Here we see the disparities by race have not been eliminated for either of these measures, but they have narrowed. Even with major policy improvements like Medicaid expansion, data like this tells us that not all communities in Ohio have access to the resources, experiences, and environments needed to thrive. We consistently find that many Ohioans, including Ohioans of color, with disabilities, with low incomes, with less education, and members of the LGBTQ+ community, continue to face barriers to health. Our speakers today are going to further explore the ways that Medicaid supports low-income people, including low-income workers, both nationally and in Ohio. So thank you all so much for being here today to learn alongside of us. If you have questions about any of the information that I shared today or want to get connected about Medicaid policy in Ohio, this is where you can reach me. I'll also head into the chat now and answer any questions that pop up there. But while you're putting questions in the chat for me, I'm going to introduce our next speaker, who I'm so pleased has joined us today. Dr. Crystal Hamilton is an assistant professor in the UConn School of Public Policy. She was previously a postdoctoral research scientist in the Center on Poverty and Social Policy at Columbia University. Her research focuses on the impact of socioeconomic inequality on vulnerable groups and the role of public policy in reducing existing socioeconomic disparities. As part of that research, she's published work on the impact of Medicaid expansion on young adult health and financial security. So welcome, Dr. Hamilton. We're so grateful that you can be with us today.
Thank you so much for the introduction, and thank you for the organizers for having me here today. I'm very happy to be part of the session. Okay, so for my presentation, I will first give some brief key facts about Medicaid before moving into my research study. Next slide, please. So first established in 1965, Medicaid is now the largest health insurance payer in the U.S., providing coverage for about 23% of the U.S. population, or around 76 million in 2024. And while 23% of the national population report having Medicaid, coverage varies by state, as highlighted in this map, with 11% of residents in Utah being covered to 34% of residents in New Mexico being covered by Medicaid. And coverage rates tend to be higher in states that expand Medicaid under the Affordable Care Act, in states with lower average incomes, and in states with the lower rates of health insurance coverage offered to employers. Next slide, please. When initially enacted, Medicaid was a program primarily for parents and dependent children receiving cash assistance with incomes well below the federal poverty level. Today, particularly due to the expansion of the ACA, under the ACA, the program extends eligibility to nearly every child and non-elderly adult in 41 states and the District of Columbia, with incomes up to 138% of the federal poverty level. So, as seen in this map, as of March 2024, 41 states, including the District of Columbia, have expanded Medicaid under the ACA, and these 41 states include 21 states that voted for Trump and 20 states that voted for Harris. Next slide, please. So while Medicaid covers almost 25% of the US population health insurance needs, it is a key source of coverage for certain populations. So in 2023, Medicaid covered nearly 40% of children, 80% of children in poverty, and almost half of all adults in poverty. Medicaid is also an especially important source of coverage for underserved groups and disproportionately covers Black, Hispanic, Native American, and Alaska Native children and adults, as well as adults with disabilities and those with special medical conditions such as mental health illness and HIV. Next slide, please. So though some may think the young and those eligible to the AC expansion account for most of Medicaid spending, in reality, spending per enrollee is highest for enrollees who are 65 years and older and enrollees who are eligible because of a disability. As with coverage rates, the percentage of Medicaid spending that pays for enrollees because of disability or age eligibility varies significantly by state. So in some states, while only a third of spending went to these populations, in other states such as Florida, these populations accounted for at least 2/3 of spending. Next slide, please. So research shows that Medicaid beneficiaries have substantially better access to care than people who are uninsured, and are less likely to postpone or go without needed care due to costs. And key measures of access to care among Medicaid enrollees are generally comparable to rates for people with private insurance. Long-standing research also shows that Medicaid eligibility during childhood is associated with positive effects on health and other non-health impacts, such as improved long-run educational attainment. Next slide, please. And recent research also shows that recent research on the impact of the ACA expansions in Medicaid has shown that Medicaid not only improves access to health care and individuals' health, but also has positive impacts on economic well-being. So various research studies have shown that the Medicaid expansion helped reduce unmet medical need due to costs, reduce out-of-pocket spending, and led to large declines in people having trouble paying medical bills or worrying about their future medical bills. It has also led to reduced medical debt, average size of debt, and the possibility of going into debt because of medical bills. And studies have also found that Medicaid helps improve broader measures of economic or financial stability. So one study, for example, found that Medicaid expansion was associated with a 2.2 percentage point decrease in very low food insecurity among low-income childless adults. And another study found that the expansion was associated with a 1 percentage point decrease in poverty. And considering that Medicaid has impacts on recipients' health and non-health outcomes, this led to my study looking at the impact of Medicaid expansion on low-income young adults. Oops, next slide, please. Next slide, please. So why study young adults? So young adults are typically ignored as a policy target population, yet young adulthood is a critical period in the life course because a successful transition to adulthood, life success, and well-being hinges on the educational achievements and employable skills acquired during this time, as well as on young adults' physical and mental health. Young adults have lower income and wealth levels relative to older adults, often lack job tenure, and are concentrated in part-time or low-wage jobs that do not provide benefits. They are also particularly vulnerable during times of economic downturn, often becoming unemployed or falling into poverty during these times. And for young adults from disadvantaged backgrounds who are unable to rely on the economic or social resources of their parents, having opportunities to increase their human capital and to ensure their physical and mental health can help them successfully transition to adulthood, as well as contribute to their upward social mobility. Next slide, please. So prior to 2011, young adults had the highest uninsured rates among all age groups within the US population. In 2009, a third of all young adults were uninsured, accounting for 20% of all uninsured persons in the United States. In this graph, I show uninsured rates from 1995 to 2000 by age categories in the US. And young adults aged 19 to 25 are represented in the purple straight line. And of note, we see the uninsured rates of young adults is consistently higher than any age group during this period. And the high rates of uninsured young adults is largely because of their transitions to in-health insurance coverage and unemployment patterns. So during this age period, particularly before 2010, many young adults experience a loss of coverage because of they aged out of Medicaid, CHIP, or their parents' employment plans, or lost health insurance coverage when they graduated from college. And employer insurance is primarily a source of health insurance coverage in the US. However, many young adults are either employed in positions that do not offer health insurance coverage or have difficulty securing stable positions. Next slide, please. So while young adults are generally considered to be healthy, uninsured young adults are less likely to report being in excellent or very good health, to engage in preventive care, or have a usual source of care compared to their uninsured counterparts. So uninsured young adults are also more likely to delay or forego engagement with the healthcare system due to costs and have difficulties paying their medical bills. They may also face economic hardships due to unforeseen medical issues, and these difficulties are exacerbated for low-income young adults who lack the resources to afford health coverage or to meet their health needs or to pay off medical bills when they do seek care. Next slide, please. So the high uninsured rates among young adults is particularly concerning, not only because of the negative impacts it can have on their health and economic well-being, but also because of the negative impacts to the public health and social systems. So disengagement with the healthcare system due to a lack of insurance can hinder the timely treatment of health conditions, including psychiatric disorders that are prevalent during young adulthood. And delayed treatment of conditions can lead to worse outcomes and reduce quality of life because it increases the likelihood of later in life chronic diseases. This in turn can increase societal costs for the late stage treatment of diseases. And the high medical costs due to the lack of health insurance can have adverse impacts on the economic well-being of young adults, particularly those from low-income backgrounds, and may lead them to be more reliant on the social safety net. Next slide, please. So while numerous studies have evaluated the impact of Medicaid expansion on the outcomes of non-elderly adults, at the time of my study, only 4 studies had specifically evaluated the impact of the policy on the outcomes of young adults. And these studies found that Medicaid expansion did help improve health insurance coverage and healthcare access for young adults, and also found that it helped narrow economic disparities in health coverage rates. These 4 studies, however, were either descriptive in nature, included all young adults in their analytical sample, or lacked state identifying information to focus specifically on young adults' health insurance coverage and focus specifically on young adults' health insurance coverage and healthcare access. And studies on the non-elderly adult population highlight that the policy had positive effects, as I mentioned earlier, on healthcare outcomes as well as on non-health outcomes. Next slide, please. So therefore, in my study, I examined the impact of Medicaid expansion on the health-related outcomes and financial well-being of low-income young adults. And I also assessed whether the policy had differential effects for racial and gender groups. Next slide, please. So to conduct my study, I used data from a variety of sources to be able to specifically identify my study sample, which included childless young adults who were aged 19 to 25, who were U.S. citizens with total family incomes less than or up to 130% of the federal poverty level. Next slide, please. And to identify the causal effect of Medicaid expansion on young adult outcomes, I implemented a difference in differences design that leveraged a variation in state adaptation of Medicaid expansion policy. So this map shows the status of Medicaid expansion by December 2017, with the blue states representing states that expanded Medicaid by 2017. Oops. And the gray states represented states that did not expand Medicaid by 2017. And to conduct my study, I compared the outcome of low-income young adults in states that expanded Medicaid by 2017, which are the blue states, to states that did not expand Medicaid by 2017, which are the gray states, both before and after the policy change. Next slide, please. So my results, next slide, please. So for my main results, I find that Medicaid expansion policy improved low-income young adult outcomes. So in this graph and the graphs I show moving forward, the bars that are represented in blue show outcomes that where I found the effect of the policy. So while Medicaid expansion did not increase the probability of young adults having any type of health insurance coverage, the probability of Medicaid coverage among low-income young adults in expansion states increased by 8.4 percentage points after the policy change relative to low-income young adults in expansion states. Next slide, please. However, I find that the policy had no impact on young adults' physical and mental health status. So compared to young adults in expansion states, young adults in non-expansion states, young adults in expansion states experience no meaningful change in their assessment of being in poor health or being in physical distress or psychological distress. Next slide, please. When looking at measures for healthcare access, I found mixed results. So while the policy had no impact on young adults' mental health outcomes, I find significant effects on being able to afford needed mental health care and prescription medicine. So compared to young adults in non-expansion states, the proportion of young adults in expansion states that could not afford mental health decreased by 2.6 percentage points, and the proportion of young adults who could not afford prescription medicine decreased by 3.7 percentage points. So young adults were able to start affording mental health care and prescription medicine due to the expansion policy. Next slide, please. The results also show that Medicaid expansion had no impact on young adults' health care utilization. So while the probability of seeing a mental health care profession and a general doctor decreased by 2 or less than 1 percentage point respectively, this decrease was not statistically significant. Next slide, please. However, the policy did decrease young adults' worry about paying medical bills if they were sick or in an accident. Yet I found that some low-income young adults still have problems paying medical bills or paying medical bills even after the expansion policy. Next slide, please. So in addition to identifying effects for young adults, I also estimated whether the expansion policy had differential effects for racial and gender groups. And I present here the results for racial groups because I found no significant differences by gender groups. So I found that Hispanic young adults, Hispanic young adults and racial minorities have a disproportionate risk of being uninsured relative to non-Hispanic whites. So in 2009, Black and Hispanic young adults were less likely to be insured than their white counterparts, with slightly more than half of all Hispanic young adults being uninsured. And in my study, I found that Medicaid expansion led to larger improvements in coverage rates for non-Hispanic white adults, so minority adults, including Black, Hispanic, and other racial groups. So Medicaid coverage for minority young adults increased by 11 percentage points more than non-Hispanic whites. And then health insurance coverage rates increased by 11 percentage points, again, more than non-Hispanic whites. Next slide, please. And when comparing results, when comparing impacts of the policy for Hispanic young adults relative to non-Hispanic young adults, I found that for Hispanic young adults, the policy had a larger impact on their coverage rates as well. So Hispanic young adults, their Medicaid coverage and health insurance coverage rates increased by 10.9 percentage points and 13.5 percentage points more than non-Hispanic young adults. Next slide, please. So taken together, my results show that Medicaid eligibility expansion policy increased low-income young adults Medicaid coverage, aspects to health care coverage, mainly access to mental health care and prescription medication, and the consumption of prescribed medication, as well as their financial well-being. The policy also had greater impacts on racial minority relative to their non-white counterparts, their non-Hispanic white counterparts. And it's important to note that the healthcare access measures for which I found significant effects are measures that are related to young adults' economic well-being and their ability to afford care services. In additional analysis that I did for this project, I also found that the expansion policy led to some young adults, low-income young adults, changing their coverage rates from other kinds of public-sponsored coverage or governmental coverage to Medicaid after the expansion policy. And taken together, these results highlight that Medicaid is meeting a crucial need, both health and financial, for low-income young adults, particularly when considering the vulnerability of this group. And the fact that some young adults are changing from other state-sponsored or government-sponsored programs, it highlights that Medicaid is providing a better coverage for these young adults with respect to their healthcare needs. Next slide, please. So in terms of the policy implication, so my study, as well as studies from other researchers, highlight the important role that public policy plays in improving the outcomes of vulnerable populations. So while Medicaid is a program designed to improve health outcomes, it can also be seen as a poverty reduction policy. So because it helped decrease medical debt and decrease some of the financial burdens of healthcare or receiving healthcare, Medicaid also results in improving the overall financial well-being of Medicaid recipients. And while I find positive effects for outcomes that are pertinent to the well-being of young adults, my results highlight the need for complementary policies aimed at improving young adults' engagement with the healthcare system. So for young adults, it's not just important to give them health insurance coverage, but to also have other policies or programs in place to ensure that they engage in the healthcare system, that they're engaging in preventive care, even at that age. And the study also highlights the need for other policies to improve access to care. So disparities in access to care continue, and we have to think about disparities not just in terms of having health insurance coverage, but in terms of like geographical access. So while I found that young adults had improvements in access so that they can actually afford to see a mental health practitioner utilization in these measures, I found no significant effects. And there have been some studies to show that for some low-income young adults, one of the barriers is actually having mental health mental health practitioners who are located around their area of residence, and also having practitioners who will actually take their Medicaid insurance. So trying to have policies that help improve various types of access or remove the various barriers that vulnerable population face are important. And next slide, please. That's it. Thank you.
Thank you so much, Dr. Hamilton. It's been an active chat as people are engaging and responding to what you've shared. If you wouldn't mind coming back on camera, I have a couple of questions that have popped up in the chat to ask you, if that's all right.
Yeah.
Sure, great. Well, one question that came up is around Medicaid expansion as a driver of young adult engagement with preventive healthcare services. If that's something that you found in the research, either yours or in others, the question particularly asks about preventive services like reproductive and sexual health care that are important for young adults. So how did that come up in the research, if at all?
Yeah, so that's a good question. In this study, I did not specifically look at the different types of preventative care services that they were accessing. But I think it's important, again, because we don't see like changes in utilization. And I mean, one of the main goals of the Affordable Care Act was to have the healthcare system in the US become a preventative healthcare system. So if we're going to have like increased access or increased coverage for individuals, then we have to have them more engaged in the healthcare system and engage in various preventive practices. So I think it's important to have policies or programs that really encourage people to engage in those practices. But in this specific study, I didn't look at the different types of preventive care that they were accessing.
Thank you so much, Dr. Hamilton. And then curious your thoughts, your understanding around the impact of access to behavioral health services and addiction treatment services if Medicaid expansion is no longer available.
Yeah, I think it's going to have a really detrimental impact because, so in this study, I focused on low-income young adults. And so we know now that, young adulthood is when a lot of the psychological issues like really come to the fore. And if you think about young adults are a vulnerable population, and then low-income young adults are even more vulnerable. And they may not have been able to afford the mental health or substance abuse care that they need without Medicaid. So with the cuts happening, if they get cut in coverage, then it could have really detrimental impacts because they won't be able to afford the needed care that, for their, I guess, for their issues, so illnesses. So.
Okay, thank you very much. I believe there's one or two other questions in either out of the question box that if you wouldn't mind heading there and responding in the chat, that would be wonderful.
In the Q&A?
Yes, please. But in the meantime, while you're working on that, I'm going to introduce our final speaker, Jesse Reed. So thank you again, Dr. Hamilton. All right, so Jesse is the director of the Life Services Program with CareSource, where he oversees the department's Ohio market. Jesse came to CareSource early in 2015 when Life Services Pilot had just launched, and he's been an integral part of the team as it's developed and evolved. We're really looking forward to hearing Jesse about the program and some of their lessons learned in serving Medicaid enrollees. So thanks, Jesse.
Haley, thank you. Dr. Hamilton, great job. That's a tough act to follow, but I'm going to do my best. I've got a couple slides to kind of walk through today. Really excited to be here. I'm a huge fan of HPIO. This stuff you'll hear as I'm talking about the social determinant stuff is my love language. So, very, very excited to be here today. Next slide, please. This is a slide I always like to start with in conversations like these. It's just, I'm a visual person. This is a nice visual representation of what the social determinants of health are. I think a lot of people have heard of those lately, certainly a lot more than when we launched our program 10 years ago. But basically what the SDOH are, they're the person outside the patient. And I love this illustration because if you start from the bottom, the teal and the orange, the 20% of the healthcare stuff, the access to care, the quality of the care. The orange is the big stuff, at least I always thought about when I thought of healthcare, the health behaviors. Things like tobacco use, diet and exercise, alcohol use, sexual activity. Those are to me always the clinical stuff when I thought of kind of health. But if you look at the purple stuff, things like physical environment, especially that top kind of quadrant, that 40%, the socioeconomic factors, the education, the job status, the family and social support, the income, the safety of the community you live in, this is all the SDOH stuff. And according to research, the top quadrant, the 10 and 50% are just as important as the clinical stuff on the bottom. Um, we took a look at this at CareSource about 10 years ago, and he said, what can we do about this stuff kind of in a non-traditional, way? We have care management. We obviously focus a great deal on the bottom kind of stuff, the clinical stuff. But what can we do about the SDOH stuff? And segue to the next slide. We launched our life services pilot in 2015. So we were a voluntary program, but I always like to stop and spend some time here. And I don't read, I'm not a kind of read word for word type of guy, but I always like to stop and read word for word our vision and our mission because it's still very true and hasn't changed in these 10 years. What we look to do, our vision in our program is to provide a holistic foundation to address the social determinants that impact the members' health and overall well-being. And our mission is to make a sustained impact in our members' lives by effectively addressing the obstacles that impede progress in a member's journey towards self-sufficiency, improved health, and well-being. So next slide. There's a lot going on this slide. It's kind of busy. Broadly, this is kind of our life services. These are our SDOH pillars. You'll see there's things down here like Job Connect, Housing Connect, Food Connect, Caregiver Connect, and Peer Connect. So a broad kind of fundamental underlying. We try to address the social services kind of with pillars. What we're going to be focusing on today the most is on the left side, the workforce development stuff, what we call our Job Connect model. Again, that's our workforce development program. I mentioned we're a voluntary program, so members can opt in and opt out of the program anytime they want. Members in our program are provided a life coach to assist with employment and or education goals and help with other SDOH barriers. And we facilitate access to community-based resources as well. So my next slide and my last slide, there's a lot going on here. We're going to spend the rest of my time actually on this slide, kind of talking through these things. But these are the things I wanted to kind of raise to the surface today for us. So first, before I get rolling here, number one, my favorite one, the relationship is the thing. I'm going to circle around on this theme throughout this slide. But first, I would like everyone on the call to just take a few seconds quietly to yourself and reflect on kind of those most important and influential relationships in your life, period. So what comes to mind for you? Like if you're like me, things that come to mind, these could be parents, siblings, spouse, family, friends, coworkers, mentors, just a positive influence, right? Someone that's there for you, someone that you trust, that relationship. Connected to that really is your professional network. So think about your professional network, kind of what led you to this call today. These may be someone or multiple people along the same lines as your influential relationships who introduced you to someone. Maybe they put in a good word for you professionally. They maybe saw something in you that you didn't necessarily see in yourself at the time. Someone who believed in you. And I love that last line. Like, let me repeat that again. Someone who believed in you is so important. I don't generally like to paint with a broad brush, but what we found in our life services work is that sadly, many of the Medicaid members that we serve do not have this relationship. They never had it. So no meaningful professional network, sometimes not even a single positive and constructive relationship in their life. So that relationship space, that's the gap that we try to fill with our CareSource members and life services. So the second bullet, if the relationship is a special sauce, then the coach approach is our secret ingredient. So the life coach role. So we call our member-facing role in life services our SDOH quarterback. We call them a life coach for a reason. So maybe some of you all on the call today, maybe you've worked with a professional coach, a leadership coach, an executive coach, maybe even a certified life coach, something like that. The coach approach is a little different than traditional social work and case management. It's more focused on challenging the member to kind of create their own goals and to take action steps towards those goals themselves with the constant support of the life coach, of course. We do the traditional case management stuff and wraparound support, but our main focus in life services with our members, it's to empower and inspire the member to improve their own lives. And so an example I always like to give is a resume. So a lot of times a member will come to us and they're looking for a job. And one of our first question is, great, you can tell me about your resume. Is it updated? Is it, do you have one even? So some programs would kind of, if a member tells us they don't or it's not up to date, we do not do the resume for the person. We will help the person do the resume for themselves. Even if that means going to a library and sitting next to them in a computer, we teach the member kind of how to do their own resume. So they have that beyond the program. So that's just, in my mind, at least, it's a good kind of straight and basic example, kind of what we do and what the coach approach is. It's empowering, inspiring those members and teaching them to kind of do things on their own instead of relying on someone else to kind of do it for them. So, expectations of the kind of the coaching relationship, a positive mindset, self accountability, and a goal focused orientation. These are the big three, right? And when we talk about barriers to employment, these are subtle things, but they're super duper impactful things. So, story time. I was the first external hire to our life services program. I came to CareSource 10 years ago when we were launching the pilot. And so I spent my first year here in the life coach role working directly with our members one on one, really as we launched our pilot and tried to figure out what the heck we were doing. It was an absolutely transformative experience. I mean this sincerely when I say it really changed my life, being able to work directly with our members in that relational approach, that approach of mutual respect and self-empowerment. What I found, sadly, is it's kind of it's rare in the Medicaid space, right? A lot of our members have not been engaged in this way. They're used to coming to folks and folks, help me fix this problem for me. So I always like to share the story. One of the first member I worked with actually was on my seventh day on the job, my second day of my second week. His name was Eugene. I met with Eugene face to face at his local McDonald's. He actually took a bus there. It was about 20 minutes from our office here in Dayton, so we drove there. And I got there a little bit early, like I typically do, and was sitting in the booth, kind of waiting for someone to walk in the door. And Eugene walked in, and he was hunched over. His hat was pulled down low. His jacket was pulled down tight, almost like he was embarrassed to be there, right? And so we sat down and kind of talked with Eugene, kind of opted him into the program. We started to talk about some of his goals. And it turns out Eugene had a master's degree. It was an education. He had just fallen out of the workforce. It was to take care of a sick relative, actually. And he was having some time kind of getting traction and getting back into the workforce. So over the course of that hour, we kind of, we defined his strengths. We set out a plan for Eugene. And I'll never forget the way he walked out of the meeting. He almost strutted out of the meeting. He was confident. It was totally different than the way he walked in, because he had had kind of a coaching conversation with someone who had empowered him and reminding him what his skills were. So that's the role of our life coach in a nutshell. We are focused on positivity. We're focused on self-belief, really taking accountability for your life and your circumstances and setting your own goals, both short-term and long-term, and then staying hyper focused on working towards those goals. So, and then the life coach, of course, the traditional life coach, if you think about it, is that cheerleader in your ear. We do that as well. Of course, we connect you to the resources in your community. It's not enough just to be in your ear and tell you got this. We help with that wraparound support. But again, we're that cheerleader in your ear. If you're having a bad day, give us a call. Like these conversations happen on our team all day, every day. Remind you what your goals are and hold you accountable to those. So again, it's a relationship. So that's my second bullet. The third bullet now kind of surfacing and coming back around to the job connect stuff to workforce development. I always like to talk about that runway to employment. The pre-employment phase is so critical. And my first bullet under this talking point is the importance of soft skills. Put differently, that life coach member relationship, all we're talking about is building rapport, right? It's getting to know a member. It's a member getting to know a life coach and really trusting that person and developing that bond. It's super critical. And within that process, especially when you work with someone looking to find a job, you start to learn things about folks. So probably everyone on this call today is well aware of what I mean when I talk about soft skills. You're all actually probably very proficient in them. But if not, these are the things I'm talking about. Things like communication skills, interpersonal skills, emotional intelligence, teamwork, adaptability, all that stuff that we know are fundamental to almost any job in any field in 2025. But what we found in our work is that those concepts that we consider employment 101 baseline things are often overlooked by our job seekers. So we bring them to the forefront and we work with our members within the coaching relationship on these fundamentals during the pre-employment phase. Fundamental things like showing up on time. So we schedule meetings with our members. If we're scheduled to meet at 9:30, that doesn't mean 9:32. That probably means 9:25, actually. You know what I mean? Being there, showing up early. Dressing the part for an interview. A lot of our interviews nowadays are virtual, but still dressing the part. Putting on a suit and a shirt instead of going to an interview in a hoodie, right? Communicating clearly, selling yourself during that interview. If you have a bad day and you wake up and you have a flat tire, how do you handle that with your employer? Do you know call no show, or do you know how to call in and have that conversation with your employer, right? Super duper important soft skill things. But these are super important that we focus about in the pre-employment phase when our coaching relationship. So soft skills, super important. The next bullet here, I love this. Kind of the employment pipeline, right? It's wanting to find a job first. It's looking for a job. It's landing the job. It's keeping the job, and then it's growing within the job. Um, in this economy, at least right now, at least over the last year or two coming out of the pandemic, it's pretty easy to find a job and get a job right now, for the most part, generally speaking, right? Pretty easy to find a job and to get a job. What we know from our partner employers, we have about 250 partner employers across the state, is that they're desperate for good employees who will, number one, show up to work on time. And number two, keep showing up to work on time and stay with the company. Most will even take a case by case look at things like criminal backgrounds, things like that. And if you lack experience, they'll also train you. So employers in 2025 are generally really competitive for folks who will work and who want to work. But in my opinion, the first and last step in this employment pipeline are a bit overlooked. And these are some of the things we focus on with our job seekers. So first of all, why do you want to find a job in the first place? What are your skills and natural talents? What motivates you? What is your passion? What do you want to do? Not what do you think you have to do? And this always reminds me of another kind of member story, actually, from a little more recently on our caseload. We had a member working with a life coach. He just wanted to find a job. And more specifically, he wanted his life coach to help him find a job at Arby's. And so through the coaching conversations, those first couple meetings, tell me what about Arby's inspires you. And it turns out Arby's was within walking distance of this member. He had no transportation, could not afford a bus pass. And his aunt had worked at Arby's, and he knew that working at Arby's, you got a free meal a day. So that was his ambition, to work at Arby's. So after working with the member and doing a little digging, turns out the member had some natural skills in mechanic. He was interested in working on cars, and he kind of ended up wanting to be a mechanic. So his career ambition shifted a little bit, and he actually got a job at a local garage. Again, it was down the street, so it was walking distance. And this member's ambition is to own his own garage one day. So that coaching conversation probably changed that member's life. So I always like to bring up that story because I think it illustrates again what we do with our life coach work. Um, but next year, and staying on this employee pipeline, digging a little bit further here, a hypothetical we always use with our members is, if we snapped our fingers today and you magically landed your dream job tomorrow, would you be ready? Things like transportation. Could you get there? Either could you drive your own car? Could you carpool? Is it on a bus line? Can you afford that bus ticket? Things like childcare. Or if you've got children in the home, could you get them to school okay? Or is it safe and affordable childcare? Things like that. Work clothes. If you've got a job and you might need a pair of steel-toed boots on day one, can you afford that? Can you connect to a community resource that has that stuff? So those things that are kind of prerequisites, that if you magically land your job tomorrow, could you be there? A callback here. These are all the SDOH stuff, right? So we challenge our members. Do you have these sorts of things under control? If you don't right now, that's fine, but let's recognize that. Let's call that out, and let's work on a plan here in this pre-employment phase. So, and then lastly, but super importantly, especially to our conversation today, what can you do once you're in the job to grow and advance within the company and or within your field, right? Maybe that's a leadership path up the org chart. Maybe it's an educational thing. Maybe it's an upskilling on the job thing. But what can you do to grow professionally and increase your income, right? Conversations like these are especially critical for someone really looking to move from Medicaid off of benefits entirely to their employer-sponsored health insurance stuff. So these are the things we kind of talk about with our members. And then segueing now to my last kind of bullet point here, the Medicaid to employer-sponsored health insurance, it's a hot topic. It'll continue kind of be a political kind of hot topic subject here over the coming years, I think. But it's my message is, it's not always a straight line. It's often a journey. It's not necessarily a direct leap. And then more often than not, it takes time. And I always got to call out the cliff effect when we're talking about stuff like this. So hypothetical, a member comes to us to say, hey, I need to get a job. I need to pay my bills. So at that point, we start to talk about and the cliff effect. For folks who don't know, it's broadly, as your employment earnings and your wages go up, your benefits tend to drop off. Makes sense, right? If you're on, whether it's TANF, SNAP-WIC, if you're receiving a baseline level of benefits, if you start to earn wages, those benefits start to kind of dip down a little bit. And often, depending on, it's very, very kind of case by case. But at a certain point, those earned wages do not fully make up for the loss of total benefits, at least for a period of time. And that gap is called the benefits cliff. From a member's perspective, you can imagine this can be super frustrating. Hey, I'm trying to do the right thing and work. I'm trying to kind of stay employed, but it's not making sense to my bottom line. So why am I even bothering going to work, right? In our program, we call this out to our members all the way back in that critical pre-employment phase that I spoke about a few minutes ago. Conversations like, hey, I know you feel like a job is going to be this magical thing and solve all your financial woes overnight. Definitely agree that's going to help you meet your goals. just understand there's going to be some bumps here and there along the path to success. So our focus is more on how can we help you plan financially to connect the dots to build that bridge across this, hopefully temporary benefits cliff, with things like budgeting, referrals to local community resources, et cetera. How can we plug you into those community resources in the area you're already living in to help you kind of, navigate that benefits cliff? So basically, we're calling out the approaching elephant in the room as part of our coaching relationship. So our members are not blindsided kind of once we get there. And then I kind of close on this cliff effect bullet because this all can be a journey, as I kind of mentioned. We commit to being there for the long haul with our members in our life services program. So once you're engaged in our program, we work with our members for up to 2 years, regardless of whether they fall off CareSource or not. So, for example, if you're a CareSource member today, or you're the parent of a child CareSource member, and you start working with the life coach, fast forward 60, 90 days, you're working, it's going great. You're off of Medicaid, you're off of CareSource. We still stay on with that member because we know it's a journey. We know bad days happen. We know you can fall back on and off a job. So we're there with our members voluntarily at their pace. So that's something else I always like to kind of call out here. And then lastly, I kind of close with my last bullet here under the cliff effect. Super important. If there's no other takeaway from what I say today, understand, please, stabilizing the other things swirling around in a person's life is critical to success on the job. So if you're talking Medicaid folks, especially, you can't really talk workforce development without having a plan for things like housing, transportation, food insecurity, childcare, all that stuff. This bullet's pretty self-explanatory at this point, but I close with this again because it's the biggest takeaway here. The social determinants of health are critical in everything, including workforce development. And that's my time. Haley, I stuck the landing. We got time for questions.
We have a couple minutes. Thank you so much, Jesse. And we do have a few questions that have come in that are sort of about nuts and bolts of how the program functions.
Sure.
So I'm hoping we can just like rapid fire a couple of these before we close out.
Sure.
All right. So how long does a life coach work with a person? Do they stay involved until all the SDOH needs are met? What does that look like?
Yeah, so we say 2 years. That's what we put on paper. It looks great in a slide deck. The reality is we've never told a member we won't work with you anymore. So really, as long as it takes. It's voluntary. It's really case by case. So as long as a member wants to work with us, again, regardless of whether they fall off CareSource or not, that life coach relationship kind of continues.
Great. How do people get connected to life services? What's the referral pipeline for you?
Yeah, so we're on our website, of course, and so it's no wrong door entry. You can call in your member services line on the back of your card. They'll connect you to our engagement specialist. She's at the front end of our pipeline to connect you with a life coach in your area. So that's how. No wrong door. Our website's the easiest way. We have an email inbox. We have a hotline, and we're voluntary. So anyway, members find us.
What are your relationships with employers like?
Yeah, so they're handshake agreements. They're not contracts, right? So we obviously don't take money. We are not a temp service. It's basically employers kind of look at us cross-eyed, like, of course we would partner. Why don't we want to partner with you? Like, because employers are looking for good people, and we, in our minds, we got a strong pipeline that we're developing of good employees. So we try to serve as that professional reference. So again, it's about 250 partner employers across the state. That we can kind of plug folks in their community. Say you're a member living up in the Cleveland area and you've got an interest in, working manufacturing, warehousing. We probably got a handful that we can kind of shepherd you through the pipeline and at least hopefully help you get an interview and stand out.
That's great. All right. That's our time. Thank you so much, Jesse. If you want to head into the chat in our last couple of minutes, there may be a couple more that you can answer there. Thank you so much. All right, everybody. Thank you so much for your time today. We are really hopeful that the information that's been shared today is going to be useful to you in your effort to influence policy and improve health and well-being in our state. There are so many ways to get involved in influencing policy, both as a private citizen and as a representative of your organization. You see some of those here on the slide. And really, right now during the budget process is an excellent time to get involved in the process. So with that in mind, we're going to throw up a set of poll questions for you. We're going to ask you how you plan to use this information presented today to influence policy, as well as just some evaluation questions for what you thought of today's event. There are a few questions here, so if you wouldn't mind scrolling through and taking just a minute or two to answer these questions about our webinar. This is also a great time if you have additional questions or thoughts that you want to communicate to HPIO or to any of our speakers. Go ahead and throw those in the Q&A box. We can respond via email or connect with you at a later time if you indicate your interest to us in either the chat or the Q&A. Thank you again so much of you for able to participate today. We're really grateful. While you're still filling out the poll, I'll let you know that the slides for today's event, the recording of today's event will be up shortly within the week on our website. You could go to hpio.net/events, and that's where you'll find that information, everything for today's event, including those posted recordings and slides. All right, all. We're going to pull the poll down at some point here and show you our last slide, which just has our contact info on it. Lots of ways to get engaged with us. Please feel free to reach out. And thank you again so much for joining us today. Enjoy the rest of your Tuesday. Bye, all.